Hi, I'm Melissa Walton-Shirley, and we're coming to you live from the European Society of Cardiology meeting 2022 in Barcelona. And we are honored today to have with us Dr. Axel Diederichsen, who presented the very interesting DANCAVAS trial. So thank you and welcome. Thanks for joining us.
Thanks for inviting me.
So just to start, this was a 5.5-year outcomes trial of screening and intervention. You started out with 46,000 males, ages 65 to 74. You screened for AFib with electrocardiography, a non-contrasted CT of the thoracic aorta, abdominal aorta, and the iliac vessels, which I thought was quite remarkable, and the first time I've seen that done. Calcium scoring, blood pressure check, screening for peripheral vascular disease, blood pressure check, blood sugar check, and cholesterol level. So please tell me a little bit more about the design of your trial and what did you do with the data from there?
Oh, it was a huge trial, sure it was. So we identified those 40,000 men in the entire area of a specific part of Denmark. So we got all men, and then we told us we randomized those in two, 1/3 for screening and 2/3 were not going to screening. And so we ended up to have 16,000 men invited for the screening trial. 10,500, approximately 10,500 did attend to the screening. And the screening, it was a large trial to do. We screened for these 7 things, as you just told us. And I think the most important one we were screening for was coronary artery calcification. So if the Kaplan score was above the age mean, if the Kaplan score was above the median for age and gender, we would initiate preventive medication like statin and aspirin. And I think it's the main difference we do with this trial. I can't tell, because we did not only screen for coronary calcium, we did also screen for aneurysms and peripheral disease, atrial fibrillation, and the other things you mentioned.
So, as I said previously, I think this is the most positive yet negatively reported trial of this meeting. So what were your top line results? And you missed your primary endpoint, so please tell me about that.
So our primary endpoint was all-cause mortality. All-cause mortality, that's a tough one. I mean, we can't prevent cancer with this trial, we can't prevent suicide with this trial, but we might be able to prevent cardiovascular diseases with this trial. But our primary endpoint was all-cause mortality. Hazard ratio was 0.95 and p-value 0.06. So very close, not close enough though. But then we have got these subgroup analyses. And these are encouraging because in the age of below 70, there was a remarkable decrease in all-cause mortality. It went down to 0.89, so we could reduce the risk of dying with 11%.
That's remarkable.
It is really remarkable, yeah. And if we have defined the endpoint as everyone else will do, a combined endpoint, mortality, stroke, myocardial infarction, we did not do that. But if we had done that instead, just an ordinary outcome, we decrease risk of these 3 things with 7%.
So your main intervention was medication therapy, right?
Yeah.
So I noticed that the cost for this trial to your system, it was a relatively cheap trial, €207. Yeah. I know the US dollar stands up well against the euro, but I will tell you this, in America, you could not get this done, this degree of intense screening performed for $207. Yet this trial tells you something about the human condition, because you had difficulty getting persons to participate in this trial, even though the screening was free. Is that correct?
Yeah. You mentioned 2 things here. First of all, you take the price of the cost of the trial. We did it really cheap. But also had to acknowledge that we did not buy any CT scanners. We had them for free. And we did not buy any other machineries. You could use these for free. But we did pay the staff to do the screening. So it might not be fair what we presented. If we instead increase this with a threefold, it might be more reasonable also, I think, to other countries. If we did that, then we would still have a cost-effective trial, I believe, if you compare to other screening examinations like breast cancer, lung cancer, colorectal cancer, and so on, it is expensive to do screening examinations.
Sure. And can you speak a bit about the safety aspects of this trial? I saw a trend toward increased bleeding.
Yeah. So our treatment was plain aspirin and statin. Of course, you have to bear in mind that there might be a risk of bleeding here. And what we saw was an increased risk, but not significant, increased risk of severe bleedings, especially regarding intercerebral bleedings. It was not significant, but we have to bear in mind that there might be a risk here.
I saw there was also a trend in reduction of stroke. Yet you did not screen the carotids, did you?
No, we did not screen the carotids. And it was not a trend for a reduction of stroke. That was a reduction.
Okay. So then there's been a heavy criticism about the lack of inclusion of women in this trial.
Yeah.
Yet you started with women, but we didn't have women in the end. Can you talk about that?
We did perform a part of the study in the very beginning. We included more than 1,000 women and more than 1,000 men. And then we looked at our findings. Did the women have coronary calcifications? Did they have aneurysms? Did they have peripheral disease? And so on. And it did, but not far as much as among the men. So we thought we had to decide how should we use our money. Should we include a lot of women without any disease whatsoever? It might be a waste of money. Or should we try to focus on men? And then we thought if we focus on men and it will be negative men, it will certainly also be negative women. So that was the decision we took. Of course, we like to look at the data we have from the women, but we have no really power for that, but we can have a look at it.
If you had it to do over again, what would you do differently about the structure of the trial? Would you do anything differently? Would you select a different primary endpoint?
A lot of questions. Sure. I know more now than I did before. First of all, I've chosen another endpoint.
And that is?
Combined all-cause mortality, stroke, and MI.
And it would have been positive.
Yeah.
Absolutely.
I'm really sorry about that. And secondly, I also think we could save some money. Why not just do a CT scan?
Absolutely.
I can't tell for sure, but I like to do a CT scan and not do all the other measurements.
So did patients come in a single day for all of this screening, or did they come on different days? Was it an intensive, long duration of time it required?
It was just one day. They came and we had made appointments for, first of all, informed consent, then blood pressure measurements, then blood samples, and then the CT scan, and then off they go. It was very quick, around 1 hour.
Wow. That's really quick.
Yeah, so we tried really to do it rational, and that's also why it seemed to be cheap. It was cheap, sure it was, but the staff and work, they were really good to do the screenings. So around 1 hour, just an ordinary patient, and then back again.
I'm taken aback by the fact that it was free and so cheap, and that it only took an hour. I mean, that's remarkable.
Yeah.
So a lot of people did not come to participate in the study. Did you analyze just those who were screened?
We did do analyze these. First of all, had to emphasize that there's difference between the two groups. The ones who attend the screening and the ones who did not attend the screening, although they were invited to the screening. Those who attended the screening, they were younger, and they had less comorbidity regarding cardiovascular diseases, and also less preventive medication. So those not coming to the screening, they were older and on more medication and so on. And that group, we know, will have a higher risk of anything. So we did not publish a protocol analysis comparing those attending with the usual care. We published the entire group with usual care. But you ask me now, what was the event rate among the ones who attended compared to usual care? And that was remarkable. The hazard ratio was in the entire group 0.95. In this case, it was 0.50.
Wow, that's remarkable.
Yeah, but it's not fair to present it that way, because we know in a group of non-attendants, there's so many other things going on there, and they have a higher comorbidity and higher mortality of anything, other things.
So do you have any ideas or plans for how you're going to entice those that perhaps are more socioeconomically disadvantaged to get them to participate in these trials and the screening? What's your plan?
Those with lower economic status, we are going to look further into our current data, because in Denmark we can see education, we can see income, house income, we can see whether you're divorced or alone, we can see everything. So we can describe pretty well our population in Denmark, also in this study. So now we can see the group come into the screening trial. How did it look like in that sense also? Did we manage to get those with a lower socioeconomic status, or did they drop out of the study? So we like to, if we can, we like to help those with low socioeconomic status, because it's there the problem is. Did we help them, or didn't we do that? We like to look further into that with our current study. And our next study with the men from 60 to 64 years. In that case, we have been looking further into how can we increase our participation rate. If we send a letter with a lot of words, would it be better to send a letter with a lot of pictures? So we did do that randomized trial. I don't know the answer yet, but this pictures did increase the participation rate. Another thing, we also sent out, please come to the screening examination on Wednesday at 3 o'clock, versus we sent another letter, if you'd like to come to a screening, give us a call. This was the one we did in the DANCAVAS. If you'd like to come to the screening examination, you're very welcome. That was the DANCAVAS way to do it. But now in our second trial, we sent an appointment out, randomized half, Wednesday on 3 o'clock, and the other part, if you'd like to come, you give us a call, to see if this way can increase our participation rate. Again, we'd like to look further into these with lower socioeconomic status. Can we help them to come to a screening examination? So it's certainly a very important point for us.
So lots of data here. We look so forward to your subset analyses. So what kinds of things can we look forward to in your next presentation on this trial?
I'm looking forward to present the data on the age group from 60 to 64, sure, in some months, some years. But in some months, I hope we can present more about the adherence to preventive medication. I hope we can present more about the attendance rates. I also like to present more about the socioeconomic status.
Sure. Thank you so much, Dr. Diederichsen, for joining us today and for this tremendous body of work that we have to review now, thanks to your efforts and that of your team. And thank you today for joining us on the Heart.org Medscape Cardiology.